we at Coli, we really focus a lot on studying the effects of GLP-1 RAs on different eye conditions. So here at SRS, we have an opportunity to focus on the vascular disorders. And in particular, we looked at the vein occlusions and the artery occlusions and the effect of these drugs on these eye conditions.
Absolutely. So I think, these glucagon-like peptide 1 receptor agonists like Ozempic have garnered a lot of excitement, a lot of traction because of the widespread FDA approvals. It's now approved for cardiovascular disease, we have weight loss, diabetes, and now chronic kidney disease. And so this is thought to be largely because they promote insulin release, which decreases the blood sugar, but also it helps reduce food intake, leading to weight loss. But people are now starting to see more of this anti-inflammatory property to these medications, and also neuroprotection. And so because of this, just like Dr. Rachitskaya said, we're very interested in trying to look at ophthalmologic disease. We've looked at glaucoma in our group, also age-related macular degeneration. But now I think because they've been shown to be anti-atherosclerotic, but also reduce blood pressure, we wanted to look into these vascular occlusion diseases, which can be very visually debilitating.
Yeah, it's very interesting, right? There's a lot, it's one of the hottest topics, right? The effects of GLP-1 RAs on eye diseases. And as Kevin mentioned, we've looked at diabetic retinopathy, we've looked at AMD, we've looked at glaucoma. There's work in NION and IH, which is, not necessarily retina related, but there's just so much information. And so the question is, as we think about vein occlusions, is there role of these medications, because they do modify a lot of risk factors for vein occlusions, but potentially even through their own mechanism of action, they can affect these outcomes for our patients. So that's what the study was focusing on. What we did, we utilized a large electronic health medical record database, and it has over 120 million patients in it. And so we rely on ICD-10 coding to study this disease. Now, when you use these large databases, you have to be extremely careful of how you design your study, because there's a lot of potential biases that can be introduced. So we were very rigorous in terms of identifying the patients that we wanted to study. So these were patients who were on GLP-1 RAs, and we followed them if they were had those prescriptions for 1, 3, and 5 years. Okay. And then we looked as outcomes, the events, looking, as you mentioned, at the central and branch vein occlusion, as well as central and branch retinal artery occlusion. So I'll let Kevin talk a little bit more about the findings.
And then, and also I think, like you were alluding to, one of the huge benefits to this database is, of course, the number and diversity of patients for generalizability, but also what you were hinting at, looking at some of the confounding variables, right? So BMI, A1C. So the platform allows us to perform propensity matching, which is a statistical tool that lets you sort of match patients at baseline to try to mitigate at least some concern of these confounding variables. And so we perform propensity matching on demographics, age, sex, race. We looked at chronic disease, high blood pressure. But like you mentioned, we also looked at disease severity. So we tried to control BMI and A1C at the beginning to try to make sure that we're trying to make these groups as similar as possible at the beginning of the study, so that we're trying our best, as everyone does, to try to narrow down to drug effect. But then, yes, what we found, which I think was so exciting, like Dr. Rachitskaya said, we started broad and then got more narrow. So we looked at total vascular occlusions, sort of a combination of then the vein occlusions and the artery occlusions. We saw a significant reduction in total vascular occlusions at every time point, 1 to 5 years. When we looked at the vein occlusions, we saw earlier effects. So we saw 1 in 3 years. There was a significant reduction with the GLP-1 receptor agonist usage. When we looked at the artery occlusions, we saw after 3 years, there seemed to be a significant effect. Getting into central and branch, it gets a little bit more challenging. So I think, right, we try to always start going most general to more narrow, because you start losing statistical power and becomes a little bit more noisy. That being said, for both central and branch, we saw very similar trends to what I just described for the overall trend for artery and central. But I think that will require probably more specific studies to get at that kind of granularity.
Yeah, if I think about this, what we see here, right, and I think that's the power of using this large database is to see, is there a trend? So is there something then we can design studies or look more granularly? And what we see, the big message that we see, that if we look at vascular occlusions in totality and follow them, these patients for 1, 3, and 5 years, at all of these time points, we see significant reduction.
I think it's a great question. I think that's what we were really excited to see. And I wouldn't be surprised if it's a combination of both. I think, could it be mitigating the atherosclerotic burden from reducing blood pressure, their blood sugar, and lipid profiles by helping reduce food intake? Absolutely. But like you mentioned, and I think there's now a lot of excitement over sort of steering the systemic inflammatory response to more of an anti-inflammatory response. And so some of the things that we talked about is looking at whether this could actually be leading to a very sharp reduction in the inflammation that's key to especially vein occlusions, right? When we think about vein occlusions, we think it requires damage to the blood vessels, but also inflammation. So I think that's absolutely one of the things we're excited about.
I think in general, if you think about this, when it's funny because when these drugs were developed, nobody was thinking about the eye, right? And so it's almost you have to go back, right, and study, in animal models potentially these effects to elucidate exactly the questions that we're seeing. What is it that's contributing? And I see these large database studies as a stepping stone, right? We see this trend. We need to now. You need, you could go back. So we've done with other disease states, we've gone back to more granular analysis. This large database doesn't allow us to see imaging. It doesn't allow us to see visual acuity, like that granularity that we're seeking. So you can go to, large center like ours at Coli and then study that. But then you can look at prospective studies, designing prospective studies like the one with semaglutide and diabetic retinopathy. And, I think it's just such a fascinating and fast evolving field because we also know that not all GLP-1 RAs are created equal, and is there one that's more than other? And so I think it's just a very exciting time to be in this line of research. And there's a lot of people who are contributing to it. And I think we're going to learn more as we continue actively investigating these questions.
So, and once again, I think if it is true that they're having this disease less often because their systemic disease is more controlled, that's fantastic. I think that's great. I think one of the big sort of confounders that we've talked about heavily, that's one of the biggest limitations of our database study, is more so actually the socioeconomic factors that go into being able to get the prescription for GLP-1 receptor agonists. It's really tough. It's not unique to our study. When we look at these large database studies, it's really tough to control for that. And socioeconomic status has been linked to, worsened diabetic retinopathy, AMD, access to healthcare. And so I think that's going to be something that's going to be really crucial, as Dr. Rachitskaya said, when we look more prospectively at making sure that that's not going to be an issue, right? Is access to care.
And if maybe next year we can talk about some of the work that we're doing in that realm as well. Looking at exactly the trends in prescription and utilization, because as healthcare is changing. Access to medications is also changing, and I think there's just there's now combined therapeutics. So with two mechanisms of action, and could that be more beneficial? So I feel like living in the time where there's such rapid developments and there's a lot of information about these drugs that's controversial, beyond the vascular occlusion. So it's continued learnings. I think what we need is ongoing conversation between specialties that take care of these patients. These patients are complex. They have a lot of comorbidities. And I think also there's a lot of information that's out there, even in lay press, and patients are confused, and our colleagues sometimes are confused, and I will tell you, as a practicing retina specialist, I would get messages from my colleagues who say, hey, I see this patient has proliferative diabetic retinopathy. Should I not put them on GLP-1 RAs? Because there was this whole discussion of the effects of GLP-1 RAs, particularly semaglutide on diabetic retinopathy. So I think I don't think I would necessarily state, all of you need to be on GLP-1 RAs. But what I think needs to happen is that conversation and that dialogue with our colleagues, so we make the best decisions based on the strongest evidence we have. And we're still working on generating this evidence. This is a first step. This is, a signal, a trend that we need to study in more detail to be able to make strong recommendations.
Even as a resident, I get phone calls about this at clinics. I have patients calling in who are either scared because they saw, a study or a headline suggesting a negative effect of the medication. And it's just so difficult because there's such mixed amount of evidence for some of these findings right now. But I'm really excited for the FOCUS trial, which is going to come out that Novo Nordisk, I think, is helping to fund. And they're going to try to help look at diabetic retinopathy progression with these medications and some of the complications. So I think that'll really help. And hopefully there'll be some other data that we can all parse in there too to get at this in a more prospective, controlled manner.